So we'll make a start on the next two presentations. So this afternoon you're going to hear from Emily and Simran, who are going to tell you about their placement in the University of Sheffield GP practices, and from Ollie and Casey, who were in GPA1 network. So Emily and Simran, you're up first. Do you want to ready your presentation?
Yeah, I think we're just trying to share it now.
Wonderful, thank you. So just to set the context for these next two presentations, the brief for the four students that are going to present now was to scope out what the role of an OT would look like within the two practices, and to write a business plan for those roles or role, whatever they found. All right.
Right, so we are Emily and Simran, and our placement was based at the University of Sheffield Health Service, as Nat just said. So it's one of the few primary care networks that is made up of only one GP surgery. So the surgery has around 54,000 patients registered with them at one time. And the most common age range for the patients is between 18 and 25 years old. So as the patient base is mainly students. However, the age range is actually from 0 to 60, as dependents of students studying at University of Sheffield are also eligible to register at the practice. So this was our second placement, and we were given a brief to scope the service with the aim to finding a role for the OT. So primary care is an upcoming field for occupational therapists, and in the long-term plan and GP primary care contract, surgeries have more criteria to fit regarding the promotion and prevention of health. So the implementation of the R's scheme helps to incorporate interdisciplinary working amongst primary care networks. Occupational therapists work a lot around lifestyle and promoting independence and helping to live their best life whilst focusing on well-being and their ability to participate in daily living. So for us, this was a chance to develop our leadership skills and explore an area of practice that neither of us really had much knowledge of prior to the placement.
Occupational therapists work holistically. We tend to see beyond the diagnosis and work with the patient to focus on participation and personal achievement. So on this slide, there is a model of practice that an OT might use. It highlights working with the patient to understand them as an individual and the goals that they want to achieve. This focuses on setting goals collaboratively to ensure that they are achievable and centered around the patient's values and interests. So this is Creek's 2008 model, and the benefit of this is that it's really good at supporting person-centered working and holistic approaches that an OT might use. During the initial interview stage, the OT could implement a biopsychosocial approach to understand the person as a whole, not just focusing on the symptoms they're presenting with. This model also incorporates the use of standardized outcome measures that can be used to evaluate the efficiency and progression of the interventions and cares provided. So we spent some time understanding the services available at the University Health Service and considered where an occupational therapist could fit into this. From the beginning, we found that there was a long waiting list for specific services. Most of these referrals occurred after an initial GP appointment. And from a survey that we conducted, we found that the practitioners believe that 15 minutes isn't always adequate to get a full understanding of the patient and provide adequate care for that individual. The survey also highlighted that the team at University Health Service found more specific wellbeing services were necessary and student mental health needs needed to be considered more within UHS. From the survey, we found clinicians have noticed that long waiting times are potentially decreasing patients' engagement in services. They've noticed a need for services to support patients' generalised wellbeing, as this is a void that isn't always covered by other teams at the moment. While shadowing practitioners, we found that there's a large number of students waiting to receive an assessment regarding ASD, ADD, and ADHD diagnosis. This was a large number of students that identify as transgender or are in the transitioning process, and whether that's medically or socially. As waiting times for both of these services can span over 7 years, the patients within this process could benefit from additional specific wellbeing support.
So all the data from these graphs we gathered when we did a service evaluation whilst at the surgery. So the data spans over 2 weeks, and it's an evaluation of triage nurse, duty doctor, and GP consultations. So these graphs show that different symptoms that patients were presenting with over the 2 weeks for the triage nurse. So as you can see, there's a lot of repeating themes, and a lot could be potentially benefit from wellbeing support, such as fatigue, low mood, motivation, and procrastination. So the ones in orange, we believe, are the sort of support that an OT could provide. So from 1 day's work worth of GP appointments, we found that 13.5% of patients had the scope for potential OT intervention. So this was based on the symptoms they were presenting with on the day. So these charts show how the majority of patients presenting with mental health needs preferred to book directly with the GP rather than being sent through the triage. So this is increasing the GP workload considerably, especially due to the fact that almost half of the GP appointments are mental health related. The graph shows where patients have been signposted after initial triage or duty doctor consultations. So following initial consultation, there's a heavy prevalence of follow-up appointments with GPs. So whilst patients are waiting for further input from other services, as waiting lists can be extensive, there could be multiple appointments spanning over several months.
So from our scope, we formulated 3 main areas to focus our intervention on. The first one was to focus on relieving the pressure on GPs. Most referrals to mental health services stemmed from a GP appointment, but with the increased pressures for appointments, and finding an alternative pathway would benefit practitioners and provide a smooth pathway for care. Secondly, we wanted to implement more support for patients as they wait in the interim between the point of referral and the access to service. This could also reduce the amount of time patients need to see the GP. We want to focus on finding a way to support neurodiverse and transgender patients. Healthcare pathways for a diagnosis or medical intervention can be a lengthy process. This poses a gap where patients may struggle with their well-being or need additional support with change. We wanted this intervention to be inclusive, and by incorporating this into the primary care network, we feel this would provide a safe space where patients know they are included. So, with the main areas for development focusing on the growing mental health needs of patients, the roles we're proposing aim to support patients by providing comprehensive, timely, and efficient care. So our first role is for a first contact occupational therapist. A first contact OT would have the additional skills and qualifications to assess patients before providing a unique pathway for care. Having an OT to specifically triage patients allows them to receive care and advice in a timely manner. This would facilitate a full assessment, giving adequate information for an OT to make informed choices about the patient's further support. The role revolves around an OT conducting a 45 to 60-minute session with each patient. During the session, the OT is able to listen and understand the patient's concerns and symptoms, but also look holistically at the patient's lifestyle and circumstances. So a model of assessment such as the MoHost model of human occupational screening tool would give the practitioner guidance when collecting data. MoHost provides comprehensive insight into the effect the patient's mental health is having on their occupational participation and volition. This, along with the verbal insight gained through conversation, will facilitate the practitioner in understanding the appropriate pathways for care. The session will also allow an OT to identify what's important to the patient, facilitating conversations around collaborative goal setting, therefore giving the patient more control over their care. This will also ensure that the patient is referred to services that align with their personal goals, and hopefully allow more precise and accurate referrals to services who will be most able to support them for those goals. Patients could also be referred to other practitioners within the University Health Service. When this occurs, practitioners will have a comprehensive overview of the patient and detailed notes around the Also have notes around the patient's condition, risk factors, and aims within the consultation. The longer appointments allows the patients to build a rapport with the clinician and makes the patient more able to express any concerns or experiences that may be more personal or triggering. Knowing this allows referrals to be accurate and avoid patients being rejected from other services. The implementation of this role will reduce the pressure on GP appointments, and patients will be assessed by an OT and referred to his GP appointment if necessary. This process provides patients with a complete assessment within their initial appointment and avoids patients having to repeatedly explain their symptoms and concerns. An OT also has the skills to look holistically at the patient's lifestyle and explore how their symptoms are affecting their life and ability to participate in occupation. This leads well into the formation of person-centered goals and improves the patient's willingness to participate as they are controlling their care.
So our second proposal was to make a waiting well programme. So this would be the formation of a 6-week, 6-session based programme revolving around facilitating patients to improve their lifestyle and behaviour. So these sessions would be focused on lifestyle and behaviour, self-help, promotion, information with aim to keeping patients well in the interim between referral and accessing secondary services. So these sessions would run in 6-week cycles, and patients would be able to pick 6 of the 12 sessions based on the preference as the skills they would find most helpful. So these workshops would facilitate 6 to 8 patients at a time, and these group interventions would allow students to practically participate in interventions that they can implement outside of sessions to aid their mental health. So these workshops will be run by an OT for an hour each week, and this programme is also can be collaboratively run with other disciplines in the surgery to provide specific advice dependent on the theme of the session. So each week 2 workshops would be available, but the patients would pick the workshop that they feel would benefit them most. So this encourages participation and integration with other students as well. And then our third proposal was sort of a one-to-one intervention with an occupational therapist. So this would provide more targeted and guided health promotion and intervention around neurodiversity. So an OT could have a caseload of patients that will work with on a regular basis to achieve goals set collaboratively with the patients. So these skills and techniques would focus around lifestyle techniques and utilize skills as activity analysis and routine management to facilitate the patient changing their habits. So an OT would be best placed to work with the patients who identify their main concerns around the routine and planning and self-care, time management strategies, occupational balance, managing other conditions such as ADHD, autism, dyslexia, dyspraxia, physical disabilities, and managing roles such as work, university pressure, and care responsibilities. So this can provide support for patients who are neurodiverse or struggling with the transition to a new environment. This role would also provide support for transgender patients or patients awaiting gender clinics. So where necessary and appropriate, sessions with an OT could be conducted in the patient's home, outdoor spaces to build a rapport and encourage participation with therapy. So the key aim for an OT intervention would be to enable the patient to participate in their daily occupations. So resources like the occupational self-assessment and Myers lifestyle questionnaire will help highlight to the patient and practitioners areas of rehabilitation or expansion of skills, as the most common age range is 18 to 25, and this may be a transitional period of time that may not feel prepared to be self-sufficient in university. Providing targeted and goal-oriented support can improve patients' overall health through education and facilitation of skills.
So this is a case study example of someone who would benefit from one-to-one OT intervention. This would prepare them to make the most of the care with other teams, such as the transformation team. An OT could work with them to facilitate a better management of their routine and to look at their roles and occupational balance within the week. There's also an example here of what we believe a waiting well programme could look like. As mentioned before, it would be a choice of 6 out of the 12 interventions over a period of 6 weeks. The person would be able to choose which 6 they feel would be best suited to their needs and therefore would engage more with the intervention. This, however, would need to be consolidated and developed once an OT has been brought into the practice. We are proposing that an OT joins this primary care network and able to work. Sorry, we are proposing that an OT joining the primary care network is able to work at agency for change level band 7. This is due to the extra responsibilities and skills needed within the loan when loan working. We have explored options around external providers such as OT 360 to conduct professional supervision sessions, so enable an OT to be able to develop their skills and ensure they are working within the RCOT and HCPC guidelines. We also suggest an OT has the ability to work as a first contact practitioner and has a background in mental health.
So thank you for listening, and we'll be happy to answer any questions that you've got.
And you are, Casey.
Okay. Hello, my name's Casey and I'm an occupational therapy student at Sheffield Hallam. This is our business plan for our project on our leadership placement. So on Wednesday, as Nat mentioned, we will be presenting this to the GPs. So we're going to have a 30-minute presentation there. Therefore, this is just a brief overview of our presentation with our main points highlighted. We've also created a report which we will be handing out to relevant stakeholders at the end of the week.
Hi guys, I'm Ollie. I'm the other occupational therapy student at the GPA1 practice in the White House surgery. So we decided to devise our PowerPoint similar to our report. So we have structured our presentation with executive summary, elevator pitch, background, customer and stakeholder analysis, research and data analysis before proposing options appraisals and concluding our findings. So our aim for the project was to scope out the role of an occupational therapist within the Manor and Castle ward. This is also referred to as the GPA1 primary care network. This started out with research into the ward demographics before working on site and finding anomalies to work with. Our three main business aims were to engage with stakeholders, scope out the role of an occupational therapist, and write and present a business case to the GP team at the White House surgery. This is due to take place on Wednesday and Friday. The additional role reimbursement scheme, or RARS, has been influential in the integration of allied health professionals with primary care networks. Since its inception in 2019, GPs have been using the funding for pharmacists, physiotherapists, paramedics, and surgical prescribers. Part of our plan was to present why employing a prospective OT would further alleviate pressures. This will be covered later in the presentation.
So these are the Manor and Castle ward demographics, and we've put a few examples of these on the slide, but more detail of these can be found in our report. So how is this relevant to the Manor and Castle ward, GPA1 network and the primary care network to support GPs? So occupational therapy is about supporting people of all ages overcome challenges to perform tasks and activities they want to go and also that they need to do. So having an occupational therapist in the Manor and Castle ward can support these affected by systematic barriers and health deprivation. As a big area for concern we found were the social determinants of health within the area due to it being one of the most deprived wards in Sheffield. So we have found that within the GPA1 network, there's a large scope available for an occupational therapy role. These are the main 6 areas we found on the slide. So first is equipment, adaptations and housing. So through observation in GP consultations, we found patients having difficulty with their housing in immediate environments. So by employing an occupational therapist, they could address these needs. For example, a patient had an issue with getting up the stairs, so a stairs assessment could be conducted, and if a stair lift was needed, the occupational therapist could put a stair lift referral in. This can be forwarded to the council by the primary care OT. Another area an OT could work in would be signposting and referrals. So through an investigation, Ollie and I found that there were many services available within the Manor and Castle ward area, which an OT could refer and signpost to. An occupational therapist has longer consultation times in comparison to GPs. Therefore, they'll be able to spend longer times picking through these services, making sure that they meet patients' specific needs. Another area is frailty and falls intervention. We were lucky enough to shadow a frailty occupational therapy specialist from Townships 1. We found a lot of information through shadowing this OT, one of which being that OTs can refer to Mediquip for larger items like purchasing stools, but for smaller items like a tap turner, the patient has to invest in themselves. Therefore, it is important to be mindful of financial situations. More information about shadowing this OT can be found in our report.
So we also have cognition and dementia. When speaking to OTs within the neighbouring primary care networks, there is a familiarity of reviewing and identifying traits of dementia and cognitive impairment. Both GPs and OTs are familiar with the basic 6 CIT assessment, but an OT could also do home visits and have longer consultations to observe and interact with the patient. In doing so, their findings could be relayed to those involved in the person's care. An OT may also be able to use more in-depth cognitive assessments like the Montreal Cognitive Assessment, or MOCA, and the ACE-3. Fatigue and chronic pain. Fatigue and chronic pain usually coincides with other health concerns. An OT could go further in depth to self-care management and techniques to support activities of daily living. OTs could help patients identify barriers, but also opportunities before collaboratively actioning them. Intervention examples could involve a pain self-efficacy questionnaire. We also found mental health support, and this is the area usually where GPs are least aware of what an OT can do. So longer consultations and building rapport and working with the patient to understand their narrative, their barriers and their opportunities and the basics of what an OT can do. OTs can assign, recommend and present toolkits for the person to use and signpost external services when required.
So we created a quantitative survey and we sent this out to the 13 GPs via email. We had 46% of GPs responded to the initial email. So we proposed these 5 questions to the GPs and we have summarised their responses, if you'd just like to look at them on the screen, into bullet points and graphs.
As healthcare professionals, OTs would need to work under the appropriate policies and procedures. This includes following NICE guidelines as well as the 15 proficiency standards of the HCPC. Confidentiality, candour, reflection and working within the limits of your knowledge and skills are all paramount to this. In relation to primary care, the ARS funding is an add-on to the Network Contract Directed Enhanced Service, or DES. Both are interlinked, and that by 2023-2024, the DES is committed up to £24 billion worth in primary care networks across the country. This is 1.47 million per typical primary care network. We'll now move on to customers and stakeholders. So as a business case, we consider the importance, involvement and collaboration of stakeholders to help identify who is positioned where. We made a stakeholder matrix to determine this. This helped us to group those with stakeholding impact and power. All the stakeholders that were high power and high impact involved GPs and allied health professionals. Those with high impact but low power involve patients, MDT partners, and the social services of Manor and Castle Ward. The SYICB or CCG are high power but low in stakeholding, whilst the neighbouring primary care networks are the least influential.
So following on from the stakeholder analysis table, we had the opportunity to shadow and liaise with the stakeholders that are on this slide. They provided us with lots of information and supporting evidence as to why the GPA1 network should employ an OT. Once again, more detail of these interactions can be found in our report.
With the exception of the SYICB, we have been able to interact and inform the other stakeholders of our project. The MCDT is Manor and Castle's main provider for social activities and community interaction. The neighbouring PCNs have given us insight about how an LT works for them. SPA, or the single point of access, are supportive of more primary care intervention for mental health. The mental health primary care network or primary care team could also work collaboratively with a prospective OT for GPO1 and support in preventing mental health crises which SPA are referred for.
Research and data analysis. So we were provided with access to System 1 and was sent the GP surgery's weekly discharge summary to look through the patients to see who we found was suitable for OT intervention. We selected 4 patients, A, B, C and D. However, we were unable to get in contact with patients A and D, but gained consent from patients B and C and completed a lifestyle questionnaire, which me and Ollie collaboratively created together. We were inspired by the Mayor's lifestyle questionnaire for some of the questions. We conducted this consultation through the phone as we thought it'd be easier. So we asked 7 questions surrounding the key topics of environment, support, interaction and community, paddles, daddles, leisure, employment and volunteering. Both responses from patients B and C suggested OT intervention would be beneficial. We've summarised findings on the presentation slide, and more detail of these patient consultations can be found listed in our report.
We also created a quantitative survey for patients in clinic. This was done over a week and involved 19 anonymous participants. We determined background information, including patient's age, ethnicity, and purpose of visit. About 26% of participants were 35 to 44 years of age, and another 26% were 64 to 80 years of age. 73% of the participants identified as white English, and the main purpose of attendance was for a nurse appointment at 42%. This was closely followed by a routine GP appointment at 31%. This second graph determines the numerical results of our 6-question tally, which we gave to the patients. The tally used a rating scale, with 1 being strongly agree to 5 being strongly disagree. The data suggests that patients have a limited awareness of what an OT could do to help them, especially within the primary care network. The approach of integrated care within PCNs appears to be maintaining satisfaction of support for patients from their practices, but introducing an OT could further alleviate barriers and support population health and proactive care. Casey and I also did our small offsite projects, which we're not able to discuss fully in the presentation due to time constraints. However, we're more than happy to answer questions at the end, and there is more of this that can be found in the report. We'll now move on to costs and operationalizations and focus on our plans A, B, and C of the options appraisals. So we devised 3 plans. This is Plan A. It involves employing a Band 7 first contact practitioner OT specialising in frailty. The R's funding enables OT employment to be a Band 7. Having an FCP status would enable patients going straight to the OT without referral for a GP. The OT would be able to do home assessments and also liaise with care homes and supported living complexes. This OT could also conduct dementia reviews alongside the frailty assessments and alleviate the volume and pressure on GPs. The OT would have more time to support patients in enabling the equipment they needed or advising on equipment to purchase. And the OT would provide familiarity and consistency among the patients they were seeing. The only slight con to this is that they'd be lone working, and they'd be the only OT within the GPA1 MDT area.
So this is Plan B of our options appraisal. This would involve employing a Band 7 first contact practitioner, and this OT would specialise in mental health. Ideally, they would be a part of the mental health primary care network, which currently has 2 occupational therapists in, so this would give the opportunity for the OT to liaise with these as well. So the Band 7 would have opportunity to liaise with other surgeries and would be provided supervision if they was part of the mental health primary care network, as well as being based at GPA1 network. So further expertise would support the MDT and support the increase in volume of patients. Hopefully it would alleviate mental health issues before crisis point, and due to being an FCP, they could be referred directly through patient consultation. However, a barrier to this plan would be if they were not part of the mental health primary care network, then they would face lone working due to being the only OT in the network. We liaise with SAPA 5, who has 2 occupational therapists in, and we found that a barrier they faced was the lone working, as their network is not part of the mental health primary care network. And the last plan is Plan C. So this is a very long-term plan due to it employing the 2 Band 7s, which we've previously mentioned in Plans A and B, and then also employing additional Band 6s to help ease the workload. So if part of the MHPCN, the Mental Health Primary Care Network, they would have monthly supervision and they'd be part of their MDT and also be part of the GPA1 network. So the Band 7s would also be able to liaise, would also be able to supervise the Band 6s, and due to having the Band 6s, it would hopefully create smaller workloads, this reducing the waiting times between each appointment, hopefully making the OT intervention more beneficial as they would be getting it more frequently. This, once again, is, as I mentioned, is a long-term preventative approach. However, a con to this plan is the financial implications. So therefore, we'd recommend more support from the MHPCN, GPA1 network, and all other third parties involved. So this is our conclusion from what we've presented. We have successfully scoped out the role of a prospective OT within the GPA1 network.
We have considered options appraisals for up to 2 Band 7 OTs and additional Band 6. We have collected and analysed data specific to our stakeholders, including patients and health professionals, and we've concluded that GPA1 would benefit from employing an OT in terms of proactive health, preventative approaches, strategies, and managing the volume and demand of ever-increasing public need. We have just a range of references here. Thank you for listening. Are there any questions?